minute to let people come into the room. Great, I think we'll get going. Welcome everyone today to this Research in Focus lecture brought to you by the Global Health Network. Today we're in partnership with Fiocruz. Thank you very much to everyone who's joined, and today I'm delighted to be joined by our panel, Dr. Claire Wenham, Dr. Julia Smith, Dr. Denise Pimenta and Dr. Rosemary Morgan. And the discussion today will focus on the gender dimensions of COVID-19. You can find the Global Health Network, Fiocruz, the Gender and COVID Project, and Claire, Julia and Rosemary on Twitter using the handles you can see on the screen. And the Gender and COVID Project Twitter handle is gender_COVID-19. So please do go and visit. Before we begin, I'll just go through a few points of housekeeping. Firstly, just to make sure everyone is aware that this session is being recorded, which means next week you'll be able to find the recording by visiting hub.tghn.org/in-focus, which is on the screen. Each of the panel will have around 10 minutes to speak, and then we'll open the floor for questions. So please put your questions in the Q&A box, and when we start that part of the session, I'll try to get to as many as possible. Pandemics, including COVID-19, are not gender neutral, and research shows that COVID-19 is impacting men, women, and people of other genders differently. The panel today will discuss the gender dimensions of COVID-19 in 3 contexts: the UK, Brazil, and Canada. This draws on evidence from 2 gender and COVID projects across 9 contexts. I'll now introduce the panel, and to begin our discussions today will be Dr. Claire Wenham, Assistant Professor of Global Health Policy at the London School of Economics. Claire specialises in global health security, pandemic preparedness and outbreak response policy, considering global health governance, national priorities, and financing pandemic control. Claire is co-investigator on 2 projects to understand the gendered effects of COVID-19, supported by the Canadian Institutes of Health Research and the Bill and Melinda Gates Foundation. I'm also delighted to introduce Dr. Julia Smith, Research Associate in the Faculty of Health Sciences at Simon Fraser University in Canada. Julia currently co-leads the Gender and COVID-19 project and has also led projects focused on the role of civil society in the HIV and AIDS response, the political economy of the tobacco industry, and Indigenous people's health. Also joining the panel today is Dr. Denise Pimenta. Denise is an anthropologist and researcher at René Russiou Research Institute, Fiocruz Minas, which is part of the Oswaldo Cruz Foundation. Denise is a member of the Fiocruz Social Sciences COVID Observatory and one of the coordinators of the COVID Social Impact Research Project funded by the Brazilian government. She's currently coordinating with Claire and with Gabriela Lotta on a Bill and Melinda Gates funded research project about gender norms in vector control programs, women in science, and COVID-19 gender issues, particularly among health workers. And our 4th panelist today is Dr. Rosemary Morgan, Assistant Scientist at Johns Hopkins Bloomberg School of Public Health in the Department of International Health. Rosemary is a co-investigator on a project exploring the gendered effects of COVID-19 in Bangladesh, Kenya, Nigeria, DRC, and Brazil, supported by the Bill and Melinda Gates Foundation. Rosemary is also an advisor on a project funded by the Canadian Institutes of Health Research, exploring the gendered effects of COVID-19 in Canada, the UK, China, and Hong Kong, and coordinates a Gender and COVID-19 working group. So today, Claire will open the session, providing an introduction to the gendered impacts of pandemics and epidemics, including COVID-19, as well as reflecting on lessons from the Ebola and Zika outbreaks, and also introducing her work from a UK perspective. And following from that, both Julia and Denise will bring perspectives from their research in Canada and Brazil, respectively. And finally, Rosemary will consider how to ensure gender-responsive preparedness and response plans. And with that, I'm pleased to hand the floor to Claire. Thank you, Claire.
Hi everyone, it's a pleasure to be with you here this afternoon, or this afternoon here in London at least. So I'm going to talk to you a bit about, in general, what we've learned about gender and outbreaks prior to the coronavirus outbreak, and also think a bit about the UK case study of this multi-country case study that we're working on together collectively with Julia, Rosemary and Denise and several others. So the first question we need to ask when we think about gender and outbreaks of disease is simply, do we have data to make good assumptions or make good decisions about whether there is a gendered effect or a sex effect in outbreaks? And so looking at the data, though, we don't necessarily have it. So this here is a graph showing the reported coronavirus cases by age and sex. As you can see, we do have some good data here. We have got some data which is disaggregated both by sex and by age, but it's simply not enough. So the UN Women, for example, is collating data from the World Health Organization reported cases, and they currently only have about 44% of global cases in their database because the rest simply isn't being reported. So whilst we can say at the moment that we think incidence is about the same between men and women, and we know that mortality is skewing towards men than women, we don't necessarily know if that is true in the community, for example. We don't know whether it's true across all samples because we simply don't have the data. And so my first plea is for anyone listening and for governments to really focus on getting that data, because without that data, you don't know what's going on. This was shown really acutely in the Ebola outbreak in West Africa, when prior to collecting or prior to publishing and disaggregating data of the cases, we didn't realize that a key part of the transmission was happening in homes. And it was happening in homes because, and we saw this because more women were getting infected at certain locations than men. And it became clear that this was because of women's caregiving role. They were either caring for sick patients, caring for children, doing the washing of bodies, preparing for burial. And so actually having this data is really important. And it's not just the data on incidents. It's also really important to get good data on labor forces and who's doing what. This chart I'm showing you now shows along the x-axis the increased feminization of the labor force. So which sectors and which workforce roles are normally dominated by women compared to men. And on the y-axis here, you've got those who are most exposed to people in their day-to-day life and therefore most at risk of coronavirus outbreak. And as you see, the ones that are highlighted in the top right-hand corner there are the people that are most at risk of the outbreak, right? And they are, without any surprise, health professionals, right? Healthcare workers. And we know that healthcare workers are 70% of the global health workforce are women, right? We know that healthcare workers are women. And that's why when we look at the data, we also have to ask about the accuracy of how the data is being reported. Is it that in, for example, the under 45 age groups, where in some countries we are seeing more women than men being infected in the official statistics, is that community-wide, or is it simply the testing policies which are showing that if you're only testing healthcare workers, you're going to see a bias towards healthcare workers? And this has been seen quite clearly through the share of all the healthcare workers that have been infected in Spain, Italy, and the US, for example, are around 70% female, which reflects broader trends of who's doing the work in the healthcare workforce. And again, we need to unpack that to look at, well, it's not just women that we're worried about. It's not just the gendered effect. This is some data from the British Medical Association, which shows the amount of people who have died, or the amount of healthcare workers that have died in the UK as of May. So it's a little bit out of date, but it's the most up-to-date data we have of coronavirus outbreak. And it's not across all sectors of our health service. It's particularly amongst British, Asian, and minority ethnic groups that we're seeing the death amongst healthcare workers. And if you look at the bottom two rows of this, which shows you the percentage of BAME medical professionals who have died compared to that percentage in the workforce, you're starting to see a difference here, which is really important to look at. When we think around this kind of formal care role that women play in the healthcare service and in the healthcare sector, which is vital to understanding the gender dimension, we also need to think of the informal care work that women do in the homes. So if you look at, for example, Feminist International Political Economy, which looks at norms around social reproduction, so the household activities which are central to the production and reproduction of life and capital, right? So what's going on when, for example, schools close? Who's doing the childcare? Who's doing the agricultural labor? Who's doing the cooking and the household work and the maintenance? Now, this is something we've seen across other outbreaks previously. So we've seen, for example, in the Zika outbreak in Brazil, that when the outbreak happened, it was the women who were left to care for children. You know, many men or many partners left the mothers with children born with microcephaly. So we see these social norms of caregiving and doing the kind of domestic burden really increase during the outbreaks. And this is no different here within the UK, for example. What happens when coronavirus emerges and the outbreak, you know, here and the schools shut and, you know, everyone's stuck at home? Well, it tends to be women who perform these additional responsibilities of cleaning, cooking, the mental load for managing all this, right? And what we're seeing quite interestingly through our data from the UK is that it really has fallen down these gendered domains, right? Women are either choosing to be furloughed, which is the UK government scheme to provide a basic income for people if they're unable to go to work because of the outbreak. Women are choosing or taking voluntary furlough to be able to perform their caregiving responsibilities at home, much more so than men are. And those women who continue to work are doing so around doing childcare as well. So they're doing more childcare and doing their paid employment. And what we're seeing, for example, is changes to working patterns. So we're seeing women get up much earlier in the morning and stay up much later at night to be able to do their paid work. So this is a really important issue that we need to think about when we think about the impact of this more broadly. And the reason we need to think about this is because it has a lot of downstream effects. So again, some polling data we did in the UK has shown a significant impact on women's well-being as a consequence of the outbreak. So although our data show that both women and men's satisfaction has fallen dramatically since lockdown started, it's fallen much more significantly for women than men. We're also seeing women report much more levels of anxiety than men, and particularly mothers of young children are the most anxious. This is really important. We're going to have lots of broader concerns within the health system if we don't recognize the mental health burden of these women. We also know that there are longer term economic impacts that women need to think about. If these women have given up their jobs, for example, to perform this domestic role, what does that mean for their long-term employment? When the inevitable redundancies happen in the UK, when the furlough scheme ends, are these women, by default, having said that their work is non-essential and that companies can continue without them, going to be the first in line to be made redundant? And that raises a big issue for women's participation in the labour force. Now, this comes at a time when the UK government has also told companies they no longer have to report the gender pay gap. So we're not necessarily getting this good data around, are women in the workforce, what are they getting paid differently? Because these decisions around who stays home with the kids and who goes back to work aren't necessarily driven just by gendered norms, but also by financial practicalities. Who earns the most, who earns the least? You're going to send the person who earns the most back to work. And if we don't have good data on whether men and women are earning the same, then it's obviously going to be the men who go back to work. And this has longer term impacts. So for example, during the Ebola outbreak, we saw quarantine measures close markets, which were predominantly female-led or predominantly run by female market traders. Now, men also lost their jobs, but 13 months after the first case of Ebola was detected, 63% of men have returned to work, compared to only 17% of women. So we do have evidence for this to show that actually this is a real concern and a real effect. And so we need to think about longer term planning for this, right? And it's not only the individuals who might have lost their jobs, but it's also thinking about sectors. And I know Rosemary will come on to this, so I won't talk about it too much. But here in the UK, the sectors that have been most affected by shutdown, as determined by the government's Office of National Statistics, have been the hospitality industry, the tourism industry, and the recreation industry. Now, those are heavily gendered industries in the UK that predominantly employ women. What are the industries that have been opened up by the government thus far in the UK? They've been manufacturing and construction, heavily male-dominated industries. So I think we need to think about who's doing what work, who's going back to work, and broader sectors, as well as just individuals losing their job. I know I'm out of time, and I'm going to pass over now, but I'm very happy to take any more questions as we go forward about what we've learned from previous outbreaks and also the UK case study. Thanks for your time.
Thank you so much, Claire. Julia, over to you for the perspective from Canada.
Wonderful. Thank you all for being here. And I'm going to talk about the situation in Canada. And, oops, no, it's not working. Oh, there you go. So as you can see, Canada's response or outbreak has been interesting in the fact that when you look at the sex disaggregated data, we're one of the few countries where there is data, and this is from the same data set that Claire was showing earlier from UN Women. So one of the few countries that we do see that there's more women being infected and dying of COVID. And I think this does come partly to the point that Claire made about the data quality. So in Canada, we are collecting quite good sex disaggregated data. And so we can really see this disproportionate impact on female people who identify as female. Interesting, Canada is one of the few countries that also collects data on non-binary genders. It's less than 1% of cases are people that identify as non-binary, but we are one country that does that. We do not collect data on race or ethnicity, which is a huge gap, however. You can also see on the map here that numbers of infections vary very much across the country. And one of the reasons you can see quite high numbers in Quebec and Ontario, which are the darker blue provinces, and also perhaps one of the explaining factors for the number of female mortality, the high female mortality in cases, is that we've had a real crisis in our long-term care centers, so our senior homes. And I thought today I would talk a little bit about this in the health workforce because I didn't want to repeat what's already been said. So a lot of the social and economic impacts in Canada are not that different from the UK in terms of the impact of closing childcare centers, anxiety amongst women, the economic impacts, and so on. So I want to talk a bit about this because I think it's unique, and it's also really shows how COVID is exposing the intersections between gender, sex, race, ethnicity, status in Canada as a newcomer or a citizen, and age. So 80% of our related deaths have been in senior centers. There's been major outbreaks. And these facilities are places where older people go to live and be cared for. It's a sector that across the country has been very much deregulated over the past 2 decades, which means that the majority of people who work there are working on part-time basis, which means they often work in multiple centers, and also in very insecure employment, and often for very, very low wages. The majority of staff, and the proportion does differ across province, but are generally newcomers to Canada and often racialized women. And so if you think about the people who are on the front lines of the response, you can see the people that, the people that are most at risk in terms of workers are people that are facing a lot of intersections that affect their power to protect themselves, to access protective equipment, to make decisions about their work, as well as the people who are in these facilities are people, who are vulnerable, maybe because of disabilities, because of illness, because of age. And so this has been, a real, to be, blunt tragedy in Canada that I think really illuminates these intersecting inequalities. The response in Quebec has been to where this crisis is the worst, has been to bring in the military. So we've actually seen senior care facilities taken over, or, the staff dismissed, the management dismissed, and the military come in to provide care, which is also an interesting gendered response because you're, removing a lot of people from work and bringing in a predominantly male workforce who is trained in something very different than providing care to the elderly. So this is sort of a unique facet of the Canadian crisis and response. And as I said, it really also demonstrates the gender and racial dimensions of our workforce in Canada, the people who are on the front lines. So this is some analysis, not done by myself, by Catherine Scott from the Canadian Centre for Policy Alternatives. And you can see she's taken data looking at the people who are on the front lines. And the majority of those people are definitely women. And the purple is racialized women, so women of minority race or ethnicity. And so you can see that, the majority of people, early child educators and assistants, almost 100% women, But also when it comes to home support, so the people that are working in places like senior care facilities are not only, that almost 90% women, but over 30% of those people are going to be women of racial or ethnic minority groups. And that is, a much greater portion than their representation in the Canadian economy or in the Canadian society. So you see a real gender and racial desegregation here in terms of who's on the front lines. As part of our Gender and COVID project, I've been talking to a lot of these people that are working on the front lines and looking at the impacts on their well-being as they try to provide care. And here's a quote from a woman physician here in Canada. And she said, it's been really challenging in terms of childcare. Normally the kids are in school, they have after school care, they have preschool. All of a sudden I'm having to find childcare and deal with the office and finding PPE and setting up virtual care. It's been a real challenge. I don't think it's been easy for women or any parent who has childcare duties. And I really heard from a lot of the people I spoke to that they felt that this burden of starting out, working on the front lines in essential work and organizing their home and child life really did tend to fall on the woman partner in a relationship. The words you see on the side come from a focus group that I participated in with women physicians. We just asked them to start the focus group by saying one word that kind of summed up their experience of COVID. And, you can see that these are really negative words. It was exhausting. It was infra-overload. It was traumatic. There was lots of talk about anticipation anxiety. In Canada, we have been lucky in the sense that we have not overwhelmed our health system. So we have been able to respond in a way that maybe hasn't flattened the curve, but has reduced the growth of it enough that our health systems haven't been totally overwhelmed, but just the anticipation of what was to come in March and April had placed a great mental health burden on those people on the front lines, the majority of whom are women. One thing I heard too from women working on the front line, and this quote comes from somebody who worked in long-term care, so providing care to senior centers, was that there was a real lack of clarity in terms of the response here, that she had to make decisions for herself and her team with lack of interpretation, that they had to kind of adapt what information they had and respond as quickly as possible to the crisis, and that this really placed a huge burden on them, on her and her mental health, and a huge level of stress. I would say that, I'm very grateful that in Canada we have quite a strong health system, and that we had people like this woman, at the forefront, who was able to make these executive decisions that felt safe, who felt empowered to do this, because otherwise I think we would have had a much different sort of response. And then, so finally, I just wanted to close by noting this kind of unique fact in Canada. As you see here is a picture of our chief medical officers across the country in the province, and the province is in Canada. And we have a remarkable group of women leaders in Canada. Dr. Bonnie Henry, who's in the bottom middle there, is the provincial health officer here in my province of British Columbia, and she's been celebrated globally for her leadership in the response, for doing these daily briefings that are very calm and reassuring. And I just think it's it's an interesting fact about our response, and something I'm quite proud of. And yeah, and so I was just going to end with that and say thank you very much for your time.
Thank you very much, Julia. Now pass to Denise, who's based in Brazil. And just to remind everyone who's joined us, joining and watching, that you can post your questions via the Q&A box. And we've had a couple so far, so thank you for those who posted. But reminder to everyone else, please post your questions there. Thank you very much, Denise.
Hello, I'm going to share my screen here. Let's see. So it's a pleasure to be here and to present a little bit about Brazil. So we've been collaborating, Claire and I have been collaborating, and since the Zika outbreak, and the partners in Fiocruz and LSE. And now we are expanding our work into the gender dimensions of the COVID. COVID happened, and now in Brazil, we've had many consequences. And it's interesting to hear you guys talk of all of these problems are common in Brazil, and then we have others that are very peculiar to what the political and economic situations that we have been witnessing. So very similar situations, but on top of this, we have a very unequal and many vulnerabilities that we have been challenging in our context now. So of course, the pandemic has made old vulnerabilities more visible and became new ones. So there's an interesting fighting of narrative and discourses around what's been the real problem and how many the situations that can be the responses and the control actions. So a lot of groups, vulnerabilized groups, have been made invisible, and there's a lot of denialism on science and the scientific and educational, and even the health sectors have been under attack for the last few years, and especially now under the Bolsonaro government. So on top of all of this turmoil, we have COVID. So this has been Brazil has been very unique in how we've been dealing with the situations. And we've been seeing a non-government, some authors have been calling it a non-government, a non-response, where the states, the federal and the municipal levels have been fighting between different types of responses, which has resulted in chaos, really. And I think it was yesterday, we completed 6 months now of when COVID was declared a public health emergency, and Brazil hit 91,000 deaths now. And of course, on top of all of these problems, gender and race and ethnicity and class and intersect with all types of really, really disastrous problems. So since the project is just starting now, and together with colleagues, I'm just going to present some general context and challenges really on what's been going on in the last 4 or 5 months. So the political situation, as I've said, is very worrisome, where Bolsonaro and his government, really the whole administration, is systematically vetoing indigenous rights, women's rights. At the UN, the Ministry of Women's and Rights are abstaining votes. So it's just been, I think they were just mentioned to be tried against crimes against humanities. It was just this week. So every day I tell Claire and colleagues that every day it's like a new, we don't know what's, things happen very fast. So there's been systematic undoing of human rights, of women's rights, of maternal rights. So all sorts of situations that have been very worrisome, where Brazil has been leading deaths among pregnant women, maternal deaths, especially Black women and indigenous women has been a really huge problem. So on top of this, violence against women as well is spiking, and communities have been getting together and trying to, since there's no governmental action, coordinated actions, communities have been doing bottom-up different ways of really trying to survive and doing and social networks and mutual aid for being able to put forward different types of actions to go against all of these violent outbreaks. So all of this work is on top of the Zika network of social science that we have here in Brazil, where I, together with colleagues from Gustavo Mata and the Rio de Janeiro and other states in Brazil, have, with the Zika outbreak, we've had social science from all over the country and abroad gotten together and having understand how health emergencies and these outbreaks impact on the different social aspects of Brazilian society and the whole questioning of global health and how these interfaces interact. So recently, we're also putting together an interdisciplinary center for health emergency field crews. And this project is inside of this big hub that we are putting together now with funding from the Wellcome Trust and others. And gender is going to be one of the axes where we're going to look at different vulnerabilities and narratives in different ways of how these narratives are being constructed. And we also have here the Fiocruz Observatory, where it's a hub where Fiocruz is putting together all its actions on COVID, and is trying to organize different actions. Where this webinar is one of the parts of the actions that we are putting together. We are also coordinating a COVID-19 humanities network where we're trying to understand the social aspects and on the Brazilian communities and health workers and all of these other communities that I mentioned are going to be. These are all projects that have just started. So that's why I'm presenting here some of these different actions. And the other one that we are also coordinating with Claire and partners from SGV is, and also the Pan-African Mosquito Control Association, PANCA, is looking at other diseases and other syndemics, where other epidemics such as yellow fever, dengue, Zika go on top of COVID, and how these different epidemics interplay with each other. Also, we've worked a lot with the health community workers and how they've been interplaying with the situation here in Brazil. So, what I've mentioned here in mainstreaming, the gender mainstreaming into vector control in Latin America, which has been really interesting. We've been getting starting to get some results. And here is our project that we're just starting. We're going to be looking at Brazil specifically, a lot of challenges that we're going to have, and it's very exciting to be here with you guys. And maybe we can talk a little bit towards the end. I've been reading some interesting analysis about the whole idea of global health, and now that the project is expanding to what we call the global South, how are we going to look at these different perspectives? And the idea that in solidarity and creativity, we're going to have to put forward on top of all of these social problems, political, economical, how are we going to put forward these different ways of living and dealing with pandemics? And so I think Cash and Patel, they have this interesting discussion on how global health is being challenged now in terms of context and social justice and equity. So I think COVID in its different living situations and how the pandemic is not homogeneous, and how we can deal with this in different contexts, different territories in what we call the global South. So maybe we can talk a little bit about this later. So it's a pleasure, and I'll hand it over to you guys.
Thank you, Denise. Yeah, we'll definitely pick up on those last points around social justice and equity. And in terms of our last speaker, I'm pleased to introduce Rosemary Morgan, who's going to be rounding off and considering gender responsive pandemic and epidemic preparedness response plans. Thank you very much, Rosemary.
Thank you, and it's a real pleasure to be here today. So we heard from Claire and Julia and Denise some of the findings and evidence around the gendered nature of COVID-19, as well as other pandemics and epidemics. And what I want to talk about today is, what do we do about it? What can we do about it? If we know that the pandemic is gendered, how can we create a gender responsive preparedness and response plan to address it? So we know from past experiences that pandemics like COVID-19 are not gender neutral. We've heard a lot of evidence about that today. It's very important that we think about how men and women, as well as people of other genders, are differentially impacted. Some effects are more immediate, while others are more long-term, as we've heard, particularly from Claire's presentation. And there will be differential health, social, and economic impacts. We need to think about, when we're discussing the gendered impacts of pandemics, not only differences between men and women, but also among men and women. And how does gender intersect with other social stratifiers like race, age, income, disability, sexual orientation, to create individual experiences of marginalization and vulnerability? And Julia and Denise highlighted some good examples about that in their presentations. One point I want to stress here is that the response to the gendered impacts of COVID-19 is not a zero-sum game. So while we may talk about the responses, the gendered effects on women, for example, we also know that there's gendered effects on men. But when we're talking about one, it doesn't mean that the other one's not as equally important. And we do need a holistic approach to looking at the gendered effects of COVID-19. So what is a gender responsive emergency preparedness and response plan? Gender responsive pandemic preparedness and response plans consider and address inequitable gender norms, roles, and relations between and among women, men, and people of other genders, including how women, men, and people of other genders will experience differential primary short-term and secondary long-term social, economic, and health effects. And we need to look across these different sectors. So such a plan considers and addresses the specific needs and vulnerabilities between and among women, men, and people of other genders. It takes an intersectional lens, recognizing that women's, men's, and people of other genders' experiences of marginalization and vulnerability will be influenced by the intersection of different social stratifiers. And it integrates gender considerations and responses into recovery, considering the differential social, economic, and health impacts. How do we minimize the gendered impact of COVID-19 then? Well, it is important to think about what needs to be done before a pandemic even happens, also during the pandemic itself and after the pandemic. And by taking key measures at each of these points, you can minimize any potential or realize negative impacts. And this information on this slide is taken from an article we just recently published in Nature. So if you'd like more information about this, please do have a look at that. So when thinking about before the pandemic, we need to learn from problems and solutions during previous outbreaks. And also from the first wave of COVID-19. Claire talked a lot about different impacts from Ebola. Denise mentioned Zika. We see similar trends, and we see these trends happening here. We see a redirection of resources away from maternal or sexual reproductive health. In Sierra Leone, during Ebola, the number of maternal deaths was equal to or greater than the number of people who died from Ebola due to a redirection of resources and women not going into health facilities. We're seeing an increase of teenage pregnancies and child marriage like we did during Ebola. We're seeing women returning to work later than men, and we're seeing increased rates of domestic violence. This has all happened before. So we also need systems for collecting data that is disaggregated by sex and other stratifiers. It's important that we do this so we know what's going on and how people are being differentially affected. And it's important that these systems are in place before a pandemic hits, because it is unlikely that there'll be time to create the systems when we're in the middle of a pandemic. And we all know having accurate data is so important. If something is not measured and counted, it's often treated as if it doesn't exist. It's made to be invisible. So during the pandemic, we do have to accept that outbreaks affect groups differently and that we cannot treat everybody the same. We have to now actively collect and analyze intersectional gender desegregated data across every aspect of the national response. And this is still not happening today, as Claire mentioned in her pandemic, or in her presentation, that we're still missing a lot of data. And we have to fund research about the gendered impacts of the virus and fast track into policy and strategy. After a pandemic, we need to make gender central to lessons learned for recovery and future pandemic preparedness. And we need to thinking about implementing a feminist recovery plan. I'd like to present two examples now that we've seen recently about feminist recovery plans. The first one has been implemented in Hawaii, and they've really taken the lead on this. Last month, in a vote in its local government office, the Maui County in Hawaii became the first place in the world to explicitly commit to involving and prioritizing women and gender equality in its COVID-19 recovery plan. Since then, 2 of its 4 counties have also committed to using this strategy in their plan, and both have voted to do so unanimously, and have already started to use it as a guide. A 3rd county is voting to do the same soon. Some of the principles, or the key principles that the plan mentions, the principles and practices for a gender and socially responsive recovery include women plus, and that means women and other marginalized and vulnerable groups in all levels of consultation, decision-making, and communication outreach, collect, analyze, and publish desegregated data, support women plus's economic independence, the redistribution of unpaid care work, and the circular economy, eliminate the digital gender gap among low and middle income women and their families in Hawaii, and reform the immigration system in order to guarantee immigrants' rights and eventually reaffirm our support for freedom of movement. Another feminist plan I'd like to highlight is the one coming out of Canada. And this one's not as far along as Hawaii in the sense that it hasn't been implemented at the policy level, but it does provide some very interesting information, and it kind of, I think it sort of expands on what Hawaii has done and looks at different sectors and expands across these different sectors. And they've developed 8 pillars for the plan, which provide a starting point for action and commitment and highlight important areas for policymakers at all levels of government to consider COVID-19 in their recovery measures. These include intersectionality and understanding power, addressing the root causes of systemic racism, thinking about how care work is essential work, investing in good jobs, fighting the shadow pandemic, which is gender-based violence, bolstering small businesses, strengthening infrastructure for recovery, and including diverse voices in decisions. So are we in an opportunity to build back better? Well, many of us who study gender and health systems, particularly health systems in fragile and conflicted states, speak about the need to build back better, to build structures and responses which take into account gender and other inequities and respond to them accordingly. How can we expect to have equitable outcomes if the structures and processes in which we work themselves are not equitable? And this pandemic has shown us that people are able to find different ways of working, are able to make accommodations for those who need it. And this pandemic and our subsequent response to it does give us a chance to reimagine the way things are currently done and to build back better. There is always an opportunity to come out of things and be better off, but only if appropriate and adequate responses are taken. But we have to remember that context is key. Broad brush comparisons of vulnerabilities to COVID responses have to be treated with caution. Gender and its impacts are context specific and vary between and within countries. Data collected in one context might not be applicable for another. And addressing some of the issues that women face in outbreaks highlights a broader landscapes of inequalities, and policymakers must consider and support all people at the margins, not just women. So what are we doing about it? Well, we have mentioned 2 projects The first is understanding and mitigating real-time differential gendered effects of COVID-19 outbreak. And this is being done with support of the Canadian Institute for Health Research in Canada, the United Kingdom, China, and Hong Kong. We're doing document and policy review, chat room analysis, interviews, social media analysis, and you see the website there. We've also expanded this work into a project titled COVID-19, Gendered Risks and Impact and Response, Research and Policy Guidance. This is supported by the Bill and Melinda Gates Foundation. So we've expanded the work from the CIHR project into low and middle income country context, including Bangladesh, Nigeria, Kenya, the DRC, and Brazil. And we launched our website just last Monday. So I would encourage you to please visit it. On it, we have listed a number of resources across these different country contexts. We have a gender analysis matrix that we're going to be uploading and adding to regularly that looks at the actual data coming out of these contexts across different gender analysis domains. We also have a page for our gender working group, and we invite anybody who is interested to join the gender working group with us. We are currently a group of over 300 members from across the world, from academia, civil society, multilateral organizations, and government. And we have mainly a Google group where we share resources and ideas and look for collaboration. But we also meet once a month on the Wednesday of every month to discuss in person what everybody is doing. And on the website, we have a page for the working group. It includes working group members. It includes resources from working group members, as well as the different projects that they are working on related to gender. And if you have a look at that, you can see the huge amount of work that is going on in this space. And we invite you to go to the website, click on contact if you'd like to join and send us a message. We'd love to have you as part of the group and to share the work that you're doing. Thank you.
Thank you very much, Rosemary, and everyone for your presentations today. We have a lot of questions. I've tried to do a degree of filtering. So to everyone who's joined, my huge apologies in advance if we don't get to your questions, but we'll try and find a way of addressing them through some other forum afterwards, if that's going to be possible. I think I'd like to start with the data. There's been a few questions come through on data because in your presentations, you highlighted a lot of data gaps due to data collection methods and focuses of data. So what are the initiatives at WHO or other levels to collect the data that we need to be able to make these analyses that are really essential across the different contexts that you're working in? Anyone's welcome to start.
I can jump in quickly on that. So I think the problem is that the way the outbreak has been framed and approached, particularly from ministries of health and the WHO system, is very much narrowly focused on the epidemiology, right? It's looking at case numbers, it's looking high level, it's looking at, who's infected, who's dying, who's being hospitalized. And that's not to say that's not important, right? It is clearly important to have that data, but not requiring those other issues to be, not requiring that data to be sex aggregated misses a trick. And particularly if you think back to the SDGs, which require sex aggregated data for everything, that's also a worrying sign. And then you've got to ask the question of why aren't governments sex aggregating the other stuff, right? So it's not just about the health impact. I mean, the health impact of COVID is obviously what's on everyone's mind at the moment. But I would argue that the socioeconomic effects of COVID are going to be much more severe than the outbreak themselves and much more longer lasting and affect people in much harsher ways. But we don't necessarily have that data. We don't necessarily have a breakdown of who's losing their jobs, for example. We don't have that provided by governments in all countries. So it's just pushing all institutions at national and global levels to ask that question around, are they getting good data that is sex segregated and also disaggregated by ethnicity, age, and all the variables that we know are drivers of inequality.
Thanks, Claire. Julia or Denise or Rosemary, would you like to offer perspectives from your settings?
Yeah, I would just say, in Canada, we do a good job of sex disaggregated data, and we've even had recent reports being produced by Statistics Canada around the economic impact. So who's going back to work, who isn't going back to work, and not surprisingly, we're seeing that more men, like a substantial portion of more men, are going back to work than women. What we really do not have is good data on other identifiers, so race and ethnicity, and it's an interesting debate here. So there's been some arguments that if you do produce that data, it can fuel discrimination or stigma if certain groups are identified as being more likely to be infected with COVID. That's not my perspective. I disagree with that. I think it's really important to be able to show these inequities, because I think what that data shows is an inequity in access to protection and an equity into secure housing and different data. There is some interesting data being collected at the municipal level. So in Toronto, one of the neighborhoods that has been most impacted by COVID is also the lowest socioeconomic neighborhood in the municipality. And I think that's really important to show. But I think those questions about how data is used are also very important. Claire showed the data about health workers and race and ethnicity and who is infected and dying. And I think that's a huge gap again in Canada. We're not showing that. Our government, I believe, is collecting data on Indigenous status, but they're not making it public. So we also don't know, information about infection amongst Indigenous peoples here in Canada. So there's so many gaps, and I think every context has their different gaps. And like the WHO, has an opportunity to lead in terms of trying to fill these gaps and promote a standardized collection of data. So that's all I would just say about the Canadian context.
I think from the social science perspective, data is how we look at is our lens on how we look at the world, and what we produce by the problems we construct. So this is very much true for the Brazilian context, because it's sort of like putting glasses on and not wanting to see how things are happening. So this even happened for the basic epidemiological data from the Ministry of Health, where we went through this whole, during the pandemic, we already went through 2 ministries of health, and now we have a militarized general at the center. So we've had, some authors have called this a data blackout, where the sites where we could access just basic epidemiological data in Brazil, I think it was 2 months ago, a while back, they were offline. Just basic ethical rights to access in data for COVID in general has been a big problem. And it's about how we frame how these problems are sourced. The indigenous and women and quilombolas and all sorts, because Brazil is a very big continental country. So the territories are very diverse. So if there's no, it's sort of like walking in the dark, where you don't really know how to assess the situation. And there's groups that are interested in keeping it this way. So it's very complicated, very political climate at the moment in terms of accessing data at all levels, federal, state, and municipal levels. So when we talk about gender, it's like one step even more complicated than what we are already living situation now.
And I think, touching on what's been said in all of your presentations, that the pandemic has heightened or made evident a lot of the gender inequalities that we see across the world, but it's also intersecting with a lot of other social movements at this time. So around gender inequality, but also other inequalities, have you seen, or how do you potentially see in future these social injustices and inequalities intersecting through civil society, for example?
I can start with this one. What COVID is showing us is it's highlighting inequities that have always been there. You know, they're not new, and it's just shining light on them. It's laying them bare. And in the United States, this is where I'm based, is we see that even and more so with the intersection of sort of the anti-racism movement that's happening here right now in the United States at the same time as COVID. And if I didn't present any data from the United States, but they are starting to present more, collect more data on race, and we are seeing more incidents and more mortality among African American men and women in the United States, much higher than the proportion of which they make up in the population, which shows really is evidence of the systemic inequalities that exist in this country. And COVID-19 is giving us this opportunity to really sort of come together and highlight these inequities. I think really stressing that it's not just about gender, it's about race, it's about income, ethnicity. We have to look at the intersections. We can't just treat all men and women the same. The data is showing that. I saw one question in the chat, in the question box too, about is this an opportunity to bring us all together in a way that maybe it hasn't been before? And yes, I'd say yes, it has. And the interesting thing is COVID is reaching across all sectors, right? It's not, I work in health systems, but people that are economists and social scientists and political scientists, we're now all working together for a common goal because it's affecting everything and everyone. And really highlighting and showing these inequities that exist.
Thanks, Rosemary. Did any of the rest of the panel want to comment on that as well?
I would just say one aspect of the outbreak in Canada that I didn't mention and is being somewhat ignored is amongst our migrant workers, so people that come to Canada as temporary foreign workers and work in our agricultural sector or are in different industries. And there have been some very extreme outbreaks in these workplaces that again are showing the multiple impacts and intersecting inequalities that put people at risk. And there is a very impressive civil society response led by migrant worker networks and newcomers to Canada and the temporary foreign worker movement here that's really pushing back and I think quite powerfully demanding better working conditions and more power for the people who have previously been disempowered in the workplace. So that's just one social movement that I think is really pushing for change and quite powerful.
Here on our side, social movements are what's been keeping people alive because like I said, since there's no coordinated, centralized, or even state level responses. There are some. I'm not saying everything is going wrong, but the problem is coordination and how things. So what we've seen is these movements are what have been the real force behind the Brazilian response in terms of keeping these vulnerable groups out of danger and into, or even if when they do get sick, we've seen different forms of mutual aid, access to food, just basic materials and access to alcohol. Sometimes we see in places where there's no running water to wash hands, and just basic access to masks and health service. But Brazil has a unified health system, which is very important. And even after all these years of attack and dismantling, it's still very strong. And that's why we're fighting. And the social movements have been very active, and different scientific associations and all sorts of communities have been coming together and fighting this for this system, for this unified, universal system that's so rich and it has come from so many 30 years of human rights in Brazil as health as a right. So I think this is it's contradiction. There's been a huge problem at the same time. These associations, these communities, these movements have been coming forward very strongly. So it's going to be interesting to see how that rolls on and how that plays on to the political and economical situation.
Thank you very much, Denise. We're at just past the hour, and I know that Claire and Julia have got other commitments. So I think Rosemary and Denise would be happy to stay on. So we'll continue with another few questions, but just because I know that Claire and Julia and many participants may also have to leave. So just to thank you very much for your time and to remind everyone that we've recorded this session. So the recording will be available next week. So if you look up the Global Health Network on Twitter, then you'll be able to find a link to the recording early next week. And just to thank everyone for their time, and we'll continue with a few more questions for a few more minutes if you're able to stay.
Thanks, everybody.
Thank you.
So thank you very much, Rosemary and Denise, for agreeing to stay on for a few more minutes. There was a question from Mariam, who I think is based in Pakistan, around the successes in the Global South and in low middle income countries. I think there's been a lot of discussion around the data gaps or a lot of the challenges, but what from your observations and research have been the successes in those settings?
That's an interesting, yeah, that's an interesting question. Yeah, I think it depends on how we define success, because and success for who. So there's many different ways we can look at this, but that's interesting because we tend to only look at the problems and what's been going on. But the one of the big successes that is what I just mentioned is our health system of SUS and all of these grassroots movements that have been putting all of these really interesting ways of going against them, how the government is treating. So this could be thought of as a type of success. And in other different, with the HIV movement, pandemic, with the Zika and the other dengue and other fires, other epidemics, we've had some limited success in terms of the associations, but over the last 5 years, the political situation in Brazil has been really worrisome. And one of the biggest problems for these epidemics in general is sustainability. So that in terms of what we call success, sustainability for control and prevention of all of these diseases, really, or transmittable diseases, is a matter of how these actions are sustained. Because many in sociology and other areas, there's a huge questioning of more structural problems, social problems in a capitalist society that feed into what we're seeing with these diseases. So you would have to look at more structural questions to see how we define success. I don't know if I answered.
Yeah. Okay. Can I jump in? I totally agree with everything that Denise has said. And one thing I did want to highlight, because I know this is a really important question, is I think that the COVID-19 has sort of flipped the script a little bit, which is good, about the north-south, high-income, low-income divide and relationships. And it's showing us that actually high-income countries are doing a lot worse in some cases. Some of the countries that had scores for that they had these scores about would countries be able to respond to a pandemic appropriately, and two of the countries that had two of the highest scores are doing the worst, and I believe that's the United States and the United Kingdom. And whereas the countries, especially in sub-Saharan Africa, which have experience of past pandemics, and Brazil has experience of Zika, what we have a lot we could learn from them. You know, they have these systems and structures in place, you know, and are really showing in many cases what can be done and what should be done. And it's really flipped the script. And I hope we see changes as a result of the way that global health works, that public health works, where expertise is being drawn from. One of the reasons that we've included Brazil in the Democratic Republic of Congo in the project is to learn from past experiences, past epidemics and pandemics of what did they do in their response that, you know, was effective, that should also be implemented. And I think we're going to hopefully see more positive things in the future, or positive around this flipping of the script and relationships. I've seen a lot more already commentary online about it, which is great.
Thank you both. And thank you, Rosemary. I've seen that you've been typing a few answers to some of the questions. So thank you for that. We'll definitely save all of the questions. I guess just thinking about time and wrapping up, I am going to use my chair's privilege to ask a final question around your perception of the policy interventions that are needed, both now and say in the coming months and years, to ensure that we don't slip back on some of the gains that have been made around gender equality, or to worsen some of the observations that have been made around gender and COVID and the impacts on women and men and other genders, and what from either past outbreaks or your idea from your research you consider to be the policy interventions that would be needed. Rosemary?
Yeah, sorry, I was waiting to see if Denise was we're gonna go. She's waiting to see if I'm gonna go. None of us wants to step over. So some examples of things that worked in the past, is that you're asking, lessons that we should take forward. It's a good question, and I'm always coming at it from a gender lens and gender perspective. And I would say that gender has been missing from a lot of the discussions for a long time. And I think that certain countries, especially in low and middle income countries with past experience of pandemics, we have a lot we could learn from them. Whether it's gender responsive, I can't really say. I think part of this project, that's one thing we want to look at is what measures have been taken that were really considered to be gender responsive, and what were the outcomes of it. But we do know that some of the measures were definitely effective and then we should be learning from that. And we're going to pull out which ones, you know, along the gender continuum, from gender blind to gender sensitive, specific, even transformative, you know, are the types of interventions that we should be doing. And I think that the conversations about the feminist recovery plans are so interesting, and we won't know what the outcome is going to be, but I think everyone's going to be looking closely at Hawaii, because they've actually put this into policy and practice, and thinking about, is this something as well that could be implemented in other contexts?
Denise?
Yeah, I think this is an interesting question. Yeah, we always get this question of what we put for, and I think maybe in the north-south relationship, or developed or underdeveloped, or different ways of how we characterize who we are. I think it's interesting from the social science perspective. It's important to not treat it as universal recipes that we say, oh, we have to do this, or we all have to do that, because context is so key to response and policy, and needs are so contextualized into these very different countries and realities. So I think there's no one fits all solution, or recipe of what we all have to do. But it's just, I think it's a value, and it's a position of listening. I think that's one of the biggest things that we try to put forward here in our work, in our research, which is an ethical value, if you stop to think about it, of listening to different perspectives, different needs, and including the people who will suffer the policy in sort of to sit at the table where these policies are happening. So if you're gonna develop policy for women, have women now that so these types of things. But it's a relationship of being able to listen and to understand and put yourself in other people's shoes and see what they really need. Because what we see is very uniform, centralized, top-down ways of putting policy forward. So a lot needs to change, and I think the social sciences can help with in all different, more the humanities. We've been trying to put this forward. So I think it's a way of being interacting with policymakers and putting different actors at the table.
Thank you both. I think that was a great note to end on, and I'll start closing the session now. So firstly, sincere thanks to Claire and Julia who've left, and to Denise and Rosemary. Thank you for your time, and thank you for staying on. Thank you for sharing your expertise, and thank you to everyone who's joined this lecture today, for posing your questions and for your time. Just to remind everyone again that we've recorded this lecture, so you'll find this as well as our archive and information about upcoming events by visiting hub.tghn.org/in-focus. And if you follow the Twitter handles that are on that page, you'll be able to find information about the projects that have been mentioned today, as well as all of the speakers. If you'd like to hear more from the Global Health Network, you can follow us at info_TGHN on Twitter. So just to wrap up, thank you very much to the panel. Thank you very much to everyone who's joined. And I hope that the weather is lovely where you are, as it is in London, and wishing you all a lovely weekend ahead. So thank you very much.
Thank you very much. It was a pleasure.
Thank you.
Bye-bye.
Bye.